So good evening, everyone. Happy St. Patrick's Day. Welcome to our spring 2022 virtual quarterly meeting for VCSQI. I have a couple housekeeping items to go over, and then we will jump into our agenda. So just real briefly, want to make sure everybody's familiar with the Zoom controls. This is an open meeting, so feel free to interact, take yourselves off of mute, to use the chat feature. All those good functions are down here at the bottom. Also, if you have any questions or need assistance, you can call or text Sherry or I. And here's Sherry's number. Yeah, there's the chat feature. So again, please use the chat box. That will also greatly assist us just to kind of keep track of pieces for the Q&A. So ideally, we'll defer Q&A and discussion until after all of our presentations this evening. If there are, some really pressing questions, we can always, kind of squeeze those in between segments. One other ask would be regarding our CME credits to please put your name in the chat box so we can record your attendance. Just make sure we have that. I see most people are in here in the participant window, and I'm familiar with most of the names here, but just in case, for instance, if your last name is not recorded there, we need to make sure we have the right person listed, just so we can ensure everybody gets their CME. So that's helpful. You'll get an email from VCU, and then you just need to fill out a survey online to get your credits and claim those. And with that out of the way, this is our agenda for this evening. So we have a dynamic team of providers from across the Commonwealth who will speak to the heart team approach to transcatheter valve cases. We're excited and honored to have our lineup of presenters with us this evening. First, however, though, I will introduce our chairman, Dr. Robert Shore from Virginia Heart. Dr. Shore will provide a brief welcome and some highlights from our board meeting that we just held a few moments ago. Dr. Shore.
Thank you so very much, and welcome to all, and hope everyone's had a happy green and St. Patty's Day. On the board meeting, we were talking about items for the next meeting, trying to make sure that the items are relevant, and had much discussion, and will likely be addressing controversies in coronary revascularization, new guidelines. We'll be looking again more at the STEMI VHAC data and the angiogram review, and we'll be able to have much more data. So that's very exciting. We looked at the solvency of the organization investments. We were doing quite well. We actually talked about the future, and we'll be providing updates. Will be one of the things we talked about is making sure that we have an ongoing regular process to review. One of the biggest notes for me, and a tremendous thank you, is that Dr. Cotter is our vice chair. He'll be stepping into the chair role after I step down and be the immediate past chair. So many, many thanks to Mohammed for his years of service and willingness to do this. He is the perfect person to be able to do that. So thank you very much. We also have an update that we're looking at having a couple of other organizations, hospital systems join us in the near future, and we're getting close. So we are continuing to grow and expand, which is great news for our Commonwealth. And again, I also wanted to just give a special thank you to all of the participants in today's fabulous discussion. It is truly a Commonwealth presentation with people from all over the Commonwealth presenting. And this is a great demonstration in the collaborative nature of what we try to do to improve the care and cost value for our patients on behalf of our patients and institutions and providers in the Commonwealth. So with that, thank you again. Happy St. Patty's Day. And Eddie, I'll turn it back to you. If there are any questions, let Eddie know and I can respond.
Thank you so much, Dr. Shore. And just wanted to start our meeting here with our VCSQI strategic plan and a quick look at our mission to transform cardiovascular care, to improve patient experience and value, and our vision of optimizing heart care outcomes through national collaboration, innovation, and research. So I just want to make sure that those core elements are front and center as we begin our session here. So our first presentation was prepared by Dr. Robert Lancey from Sentara Rockingham Memorial Hospital. Dr. Lancey was unfortunately called away for an emergency case, but his presence was crucial in helping us prepare for tonight's event. So thankfully, though, stepping up to the plate in his stead is Dr. Eric Sarin. Dr. Sarin is the section chief of adult cardiac surgery at Inova Fairfax and brings over 20 years of experience as a practicing cardiothoracic surgeon and a wealth of knowledge about minimally invasive and catheter-based techniques. Dr. Sarin will present a case study and set the stage for our TBT-focused agenda this evening. Dr. Sarin, it's an honor to welcome you to our VCSQI meeting tonight.
Great, Eddie, thank you very much. And I'm happy to pinch hit for Dr. Lancey because I think he really picked a great case to start things off. And so, from the organizational standpoint, when we were looking at the how we wanted to kind of set this this evening up, I think everybody on the organizational side agreed that highlighting the heart team approach and how important and special that is it really needed to be front and center. So it's my privilege really to present this case for Dr. Lancey because I think he really picked a nice one. So I guess Sherry, Eddie, if you don't mind just advancing slides for me, that'd be great. And then Dr. Lancey was nice enough he actually had some notes, so I will have something to go off of here. But so this is a case of an 89-year-old gentleman who presented with worsening symptoms of congestive heart failure, progressive dyspnea on exertion, fatigue, lightheadedness, was having some pedal edema. He was actually a pretty healthy guy, owned a farm with 20 head of cattle. But had noticed obviously that he was more and more limited in his day-to-day in terms of trying to to tend to his cows. He did have a past medical history of hypertension, dyslipidemia, had some mild chronic renal insufficiency with a creatinine of 1.3, a GFR of 50, a history of prostate cancer. And then obviously a murmur on exam and some moderate stenosis of his left internal carotid artery. Can we go to the next slide? His baseline EKG was pretty unremarkable, a little, right bundle branch block, a little bit of a prolonged PR, but otherwise in a normal sinus rhythm. Can we go to the next slide? So on echocardiogram, he met criteria for severe aortic stenosis, had a preserved left ventricular ejection fraction, but both by by gradient, velocity, and valve area, definitely a stenotic valve in the severe range. We go to the next one. Perfect. So on a CT scan, had a pretty calcified valve with a calcium score greater than 4,000. A big, nice tortuous aorta that you would expect with someone who's almost 90. A lot of atherosclerotic disease, but thankfully, limited really to the descending and the arch. The ascending is pretty free of calcium. Go to the next slide. So his left and right heart catheterization, right heart numbers were pretty decent, but then on the left side, left heart catheterization, he was found to have pretty diffuse coronary disease. So that included a distal left main, then with some proximal disease from the in the circ and in the LAD, and then also a chronically occluded right that was approximately CTO, and then a 90% PDA lesion. And if we go to the next slide, I think we have some still frames from the cath. So you can see just some diffuse disease in his left system, certainly in that LAD, but decent targets, good sized vessels, and then obviously the proximal occlusion of his right coronary artery. We'll go to the next slide. So this is when they brought it to the heart team approach. I think that initially you look at an 89-year-old guy with AS. This is somebody that I don't think anyone would really quibble with in terms of a Tavr, but having this kind of diffuse coronary disease certainly sort of muddied the waters. And so as I think we all try to do, in the heart team approach, we're going to take a nice multidisciplinary discussion of all the possible options. Dr. Lancey's done a really nice job of listing them there on the side. And I think we have the ability to do a poll. Is that right? We're going to poll the audience and see what people think?
That is correct.
Perfect. So give everyone a minute just to sort of, take a look, think about what they think would be the best thing to do. And I don't know if I'll look and see if there's anyone who wants to weigh in. I know I see Dr. Spear is on. I know Matt's on, but I also know Dr. Cotter is on, Dr. Mahoney's on. If anyone has some thoughts they wanted to offer while people are answering.
Okay, votes are still coming through.
Okay.
We're at
So
28.
while people are voting, you know, the role of revascularization with TAVR is one that we're kind of all evolving with. You know, we used to, in the trial days, we used to revascularize everybody because the trials required it. So the question becomes, you know, should we be doing stenting before TAVR, after TAVR, concomitantly? And it's a pretty interesting and controversial question right now. I'll just throw that out there. I'm not going to tell you I know the right answer, but it's kind of an interesting question in this case.
Yeah.
Yeah, I agree with Paul. It's hard to know whether it benefits the patient a lot. I will say that when it looks like it's going to be really complex, I tend to want to do it before the TAVR in terms of getting, you know, access to the coronaries. If there's any question of whether I'm going to have access to the coronaries, et cetera, then those are sometimes cases where I'll do a BAV and then do the complex coronary rather than afterward. If it looks like it would be, you know, higher risk, but not as complex, then I might do it afterward. But I agree, I don't know for what benefit yet. And the only clinical trial evidence we have indicates that there's not a lot of benefit to revascularizing, you know, LAD, left circ disease, et cetera. Left main was left out of that trial.
Eric, I think that the Pcsqi is not a chip shot. I mean, I don't do it, and so I'm speaking out of school. But there's an asterisk there that talks about stenting the left main. It's complex into both the LAD and the circumflex. And given his age and his mortality and morbidity at 22%, I don't agree with the stroke rate. If he came to an open procedure, I think it's relevantly higher than that and may approach 10 through the STS data. But I would sort of fall and agree with Matt. It may be better served recognizing you're leaving behind relevant disease, but given his age and his symptoms, should he just have the TAVR only?
Yeah, definitely. Okay, great. So we got some, I mean, all good points. So, okay. So it looks like at least the majority of people were favoring Pcsqi followed by a TAVR, which, as we talked about, that's sort of the traditional approach. And then smaller subsets looking at an open surgery versus TAVR with Pcsqi, TAVR only, and then TAVR followed by Pcsqi. So great. I think this is kind of, you know, these are the sort of discussions we have, you know, and it's one of those things where it's obviously hard to know what the best answer is. And a lot of it goes into, obviously, like Alan, Dr. Spear brought up, you know, if not every Pcsqi is going to be a chip shot, but then also I think, and as we go forward with this case, you know, not every 89-year-old is the same either. So based on extensive discussions with the structural heart team, going back where the patient obviously wanted to avoid a sternotomy if possible, but based on the extent of the coronary disease and the concern over just the complexity of Pcsqi, he was ultimately counseled and accepted an open operation. And do we have, what's on the next slide? Ah, there we go. So he ultimately underwent surgery, and this was back in January of this year. He had a surgical AVR with a 25 millimeter inspirus bioprosthetic valve and a 5-vessel cabbage. So Lima to the LAD, and then vein grafts to 2 obtuse marginals, and then sequential graft to the right, both in the main right coronary artery and then to the PDA. Had a post-operative recovery that was, I think, only about, as I can piece together, maybe about 9-10 days in the hospital. Had an increase in his creatinine, but otherwise did relatively well. Got a left thoracentesis. From reading the notes, it sounds like he was pushing to go home, despite being advised that he would benefit from going to rehab. Was home for a few days, then came back into the hospital while they got him out to an assisted living facility. Did well there, and is now back at home with his cows. So go to the, is that our last slide? Okay. So I think that, you know, this just underscores the value of having that discussion, you know, with the full team, with the patient. I think, anytime we have these complex patients that come through our valve clinic, and Matt and Dr. Spear can certainly attest to this, I think we end up talking to them multiple times. It's not usually just a one-time through and you make a decision and that's that. I mean, it's a very thoughtful discussion. You want to make sure you involve the family to really go through all the potential risks and benefits, make sure the patient and the family have a really good understanding of what the pros and cons of any particular approach would be, as well as the risk. So, as a surgeon, I'm pleased that we're starting off the evening with a surgical case. And so I'll thank Dr. Lancey again. And then obviously, if there's any discussion to bring up, we can, I guess, Eddie, you want to table that for the end, or do you want to have any quick comments before we move on? Or Sherry?
Yeah, I think we're okay for some quick comments, and if anybody had anything to top of their mind.
Okay.
What do people think about the intervening on 5 vessels at 89 for potentially asymptomatic coronary disease at the time of AVR?
Yeah, that's a great question. Did we impart a survival advantage? Was his primary symptoms from his critical AS or from coronary disease? What would you have done if this gentleman without AS had presented with that type of coronary disease? Would you have attempted to manage him medically? Because we can make the AS go away, right? We can just fix that with a Tavr valve. So for the cardiologist in the room, how many would have sent this person to surgery just for their coronary disease?
I think if they don't have a lot of symptoms, et cetera, then clearly I think medical management is completely reasonable for those patients. In this setting, if they didn't have severe AS or critical AS, obviously we're looking for benefit there, and an 89-year-old, the benefit would probably be with medicine and symptoms.
I do think if you're going to operate on him, the most complete revascularization possible. So I think, Savr plus cabbage times 5, or I would have actually voted for Tavr alone in this patient and medically managed a coronary disease. And again, with the 100% benefit of not having to actually put that to the test, it's just a theory. This guy did very well, and it's a nice case, but it's a great discussion.
Yeah, I think just to back to the point about the cabbage and the number of vessels, obviously it's hard from the still frames to know what the right-sided targets look like, but on the left side, I mean, they all look pretty good to me. And from my standpoint, once you've bitten off the sternotomy, the pump run, and the cross clamp, you may as well get a complete revascularization, as Dr. Mahoney said. And I don't think you're really going to incrementally add to risk as long as you have good targets to sew to.
I think this is a great anecdotal case, but if we had 189-year-olds that had a valve quintuple coronary, we're not going to be having this conversation. And so it's nice job, Eric. But I think we got by on this particular case, but
yeah,
it's
be fair to Eric. He didn't prepare this case. He's doing the presentation.
Never.
So.
Okay, Matt, first lesson, never be fair to Eric.
Yeah, no, but I think to be fair, this is Dr. Lancey's case, and they did a remarkable job. But your point's well taken. Not every 89-year-old is going to be the same, and that's there's something to be said for really getting to know the patients and to really I think spend time with them, get an idea, at least from a surgical standpoint, what kind of risk you think they can tolerate.
Yeah, I think that's where I was going with that question.
The other point that this highlights is shared decision making. That not everybody. Despite their age, may be functionally very different, and having that open conversation about the risks and benefits of alternatives often will lead to the shared decision making.
Not to add to bravado, Yuri, not to add to bravado in our institution, but actually since the beginning of the year, we had 2 fallouts from the structural team, from the structural program that required open heart operation, and both were, this gentleman was 89, the one I did was 88. I think in the octogenarian, the most important part is patient selection because they age very differently. And so we have some of these octogenarians who are very robust. And I think in that case, it's appropriate to offer them at least a choice of complete repair, but not every one of them will do just as well.
Very hardy stock in the Harrisonburg area.
You know it.
Great. Well, it was a great discussion, and I think probably in the interest of time, keep things moving because I know we have a full agenda. And then I know it was Dr. Lancey was going to introduce Jenny Hamby, and so I'll read what he's written here. So Jenny has been an acute care nurse practitioner in the structural heart and valve program coordinator at the University of Virginia for over 2 years, and is now serving as the coordinator of the program. She's been in the cardiology program there since 2015. Previously worked at both UVA and at the University of Florida in emergency medicine and trauma, which Dr. Lancey, I think, appropriately recognizes is good preparation for having to deal with interventional cardiologists and cardiac surgeons. So Jenny, welcome. Thank you very much for participating tonight. And I think we are all going to be in unanimous agreement about the absolute importance of having a valve program coordinator. So with that, please take it away.
Thank you for that very kind introduction. So I am Jenny Hamby. Hi, everyone. I am an NP at the University of Virginia and the Structural Heart and Valve Program Coordinator. And I will be presenting on the Valve Clinic Coordinator's role, creating the recipe for success. So, and Sherry, do I have control?
Sure.
Yeah, you should have control, Jenny. Just it says waiting for you to take control. So I think you need to click the Zoom window.
Oh, it's not giving me that option.
Okay, now it says controlling my screen. Let's just forward one. Oops.
Okay.
No, I don't think I have your slides here. I'm sorry.
Actually, here we are. Tag teaming.
Okay, we'll pass it over to Sherry's screen here.
Almost there. Okay, Jenny, you should have control. Okay, just click your screen and then you should be able to move it. Perfect.
All right. So I have no disclosures. And here are our objectives. We're going to review the core members of a structural heart team. We'll outline a patient's progression in the structural heart program from referral to post-procedure follow-up. And we'll identify any potential hurdles in their care and how we can address them. So when you are establishing a structural heart program, you first need to decide what problems you'll address. So which valves are you going to repair or replace? Will you do left atrial appendage occlusions, ASD, PFO closures, any clinical trial involvement? And once you've answered these questions, you can move on to assemble your structural heart team. So a structural heart team typically is going to involve an interventional cardiologist, cardiac surgeons, your clinic coordinator, your APPs, RN care coordinators, administrative assistants, research coordinators, and ideally an inpatient service that knows your patient population and how to care for them. And of course, the patient and their family is an important member of that team. So who is the valve clinic coordinator? In the recipe for a structural heart program, I think the clinic coordinator is the mixing bowl who keeps everything together. So they can come from a variety of backgrounds, perhaps a clinical background, administrative, maybe they have some experience in business or marketing. Essentially, your coordinator's background is going to depend on the goals of your program. We've found at UVA with the number of referrals we receive that a clinical background was best to facilitate our program's growth. So the clinic coordinator is going to serve as a team leader to ensure that patients flow through the process as efficiently as possible. They'll have a hand in quality and billing metrics to make sure your program is meeting national benchmarks. They'll work with marketing to grow your program. And importantly, they'll help put out those inevitable day-to-day fires that come up that typically require a lot of inter- and intra-departmental coordination and communication. So what is the structural heart recipe? Well, you're going to start with your referral. And from there, you'll bring the patients in for their initial visit. At the initial visit, you'll have your diagnostic testing, potentially involvement of the research team. Once you move past this step, you'll move towards the shared decision-making, which is an important model in the structural heart program, and we'll talk about that in more detail. You may decide that the patient's not quite ripe yet for their intervention, and we want to continue monitoring them closely until they're ready, but more likely, they'll be ready to move forward to their preoperative visit. From there, they'll get their transcatheter intervention and post-procedure follow-up. And if this looks convoluted, that's because it can be, and a clinic coordinator's job is to make sure patients flow through this process seamlessly. So we'll take each step individually. So step one is our referral. So as a team, you want to establish strong relationships with your referring providers so they can easily reach you. Referrals can come via multiple avenues. I know at UVA we get them through our EMR, provider-to-provider phone calls, emails, faxes, and keeping them organized is key. That's one of the, I'd say, most important roles of a clinic coordinator. So how are your referrals going to be reviewed and tracked? At our program, that's primarily done by our RN care coordinators, but the APPs and clinic coordinator serve as a backup for that because it can become quickly overwhelming. We do plan ahead, and that's a theme in the structural heart program is planning ahead for imaging that you may be able to coordinate with their initial visit, potential joint clinic candidates, which we'll talk about in more detail, and potential research candidates. So step two, we have our initial visit when we bring our patients in. Most of them are going to need some CT or TTE imaging, and they'll meet our RN, our APP, and our interventional cardiologist at a minimum at the initial visit. Our program likes to involve the APPs in the initial visit because they become the point person for the patient through their course, and we like to get them, we like to establish that relationship as quickly as possible. And then we consider joint clinic visits. So our best candidates for a joint clinic visit are those who have CT images available to review, maybe cases that are not straightforward, like the one that was just presented, maybe a younger patient or someone who's a little lower risk, bicuspid anatomy, multivessel disease, things that maybe make the decision-making less clear-cut. And also, we see patients from a pretty wide swath, and so if they're traveling from a long distance and we want to limit the number of visits they have to make here, we'll consider a joint clinic visit as well. At the initial visit, we like to involve the research team whenever we think we have a good research candidate, so they can spend their time with the patient and go over what their options are. Our administrative assistants are one of the hearts of our program, and at the initial visit, their role is to make sure patients are scheduled for the next steps. And maybe most importantly at the initial visit is patient and family education, so that they're leaving with a solid understanding of what their valve disorder is, what their options may or may not be, and what the next steps are. And so there are no surprises. So step three, further workup. Now this is going to be individualized to each patient, but you'll need to consider if they need a diagnostic cath, transesophageal echo, if they haven't met a surgeon yet, making sure to get that scheduled. Would they benefit from seeing a heart failure specialist? Are there any incidental findings that need follow-up or further referrals to pulmonology, oncology, potentially referrals to electrophysiology? And then is there any tune-up that needs to be done? Do we need to consider Pcsqi prior to Tavr? Do we need to get someone's alcohol septal ablation done to improve their LVOT for some of the trials that we're doing. Once you have all those pieces in place, it's time to have your multidisciplinary discussion. And this is the heart of a good structural heart program. It often can occur in our joint clinics, but for more complex patients or less straightforward patients, such as those for whom we're debating surgical versus transcatheter approach or access choices, we will discuss them in our weekly team meeting. And that team meeting involves a lot of players, obviously the interventional cardiologists, the surgeons, our APPs, our nurses, our admin assistants, because there's a lot of rescheduling to discuss at these meetings, PT, OT, our inpatient team, basically anyone who is involved in our patient's care, we want involved in the discussion. So once you have this discussion, assuming that the team and the patient agree to move forward with their intervention, we bring them in for their preoperative visit. This visit is typically driven by our RNs and our APPs. The goal of the pre-op visit is to send the patient home with all of their questions answered and a solid understanding of their structural heart disorder and how we plan to fix it. Of course, we review all the risks and the benefits of the procedure. I also like to make sure to give them a vision towards the future as to what they can expect post-procedure in that first month and then long-term, so that there are as few surprises as possible. And at the preoperative visit, we like to use multiple modalities for education, like the models you see here, videos, written instructions, whatever works best for the patient and their family. So step 6 is the intervention. There is a lot of coordination of multiple departments around the procedure itself. So we have the cardiac transition unit, which is our periprocedural area. That's where our patients arrive. Then we have the cath lab and anesthesia if they're going to be needed for the case. Then we have our inpatient services, PT and OT, case management, and everything that comes along with that. The clinic coordinator's role is to ensure all of these stakeholders understand the plan, understand any complexities about the patient that may need to be addressed, and that they all have the education they need to move the patient from arrival to intervention to discharge home. So once they have their procedure, we set them up for our follow-ups, and that ranges, depending on the procedure, from maybe 1 month to 1 year, and if there's research involved, maybe more frequently after that. But typically at every follow-up, you're going to have some kind of imaging, an echo primarily. They will meet the RN again, the APP, our administrative assistants are instrumental in making sure patients don't fall through the cracks. We'll discuss any tune-up needs. Do they need a little more diuresis or any other medical management? We'll make sure that all of the TVT registry requirements are done, the KCC-Q12s, et cetera. If research is involved, this is their time to spend with the patient and get all their screenings done. Of course, patient and family education is an important part of the follow-up. We talk a lot about antiplatelets, anticoagulants, SBE prophylaxis, and what to expect, what's down the line. And so we also ensure that they have follow-up with a general cardiologist and a referral in place with cardiac rehab. We also sometimes have to do a lot of convincing to some of our patients that cardiac rehab is beneficial. So I'd say those are the key points of our follow-up appointments. So what are some potential hurdles to getting a patient from referral to follow-up? One thing to consider is socioeconomic needs. Are there financial limitations? Is there any health illiteracy, language barriers, transportation concerns? You know, a lot of our little old grandmas, they don't want to call their kids to ask for a ride to Charlottesville because they don't want to burden anyone. But then you talk to the children and they say, this is absolutely not a burden. So having that conversation early on is important. And then do the patients need any assistance with their activities of daily living? Are you going to have to plan for that post-procedure? So what are some possible solutions? Making sure to involve the family, invite them to clinic visits when visitor restrictions allow, whether that's in person or even by phone, by speakerphone in the visit. Make sure to enlist social work when necessary. Our physical therapists are involved pre-procedure. Any smoking cessation counseling that might be helpful. And then looking into partnerships with your local hotels and hospitality houses so that patients could potentially avoid multiple trips back and forth. We also will utilize telehealth visits and joint visits whenever we can, and of course, enlisting our certified translators. What are some patient-centered hurdles? To start, there is sometimes some procedure hesitancy, especially at the initial visit. Patients might have some secondhand knowledge of a neighbor's uncle who had a Tavr and had some vague complication, and they want to know more about that. Or they Googled the procedure and happened to read all of the possible worst-case scenarios that happen to less than 1% of patients. There could be anxiety about adequate sedation. Maybe they had a procedure in the past they didn't feel they were appropriately sedated for. And questions about anticoagulation, a common one, especially in our population, is, will I need to be on a warfarin for the rest of my life? And so spending a lot of time clarifying these questions for patients is very important at the initial visit. We also want to be sure to identify any cognitive impairments as early as possible at the initial visit. So we do frailty screenings, which involves many cogs and the clock draw that you see here. It's very helpful to identify any cognitive decline that may not be apparent initially, because it can absolutely affect their post-procedure recovery. And then what are some possible solutions here? Providing education in multiple modalities at a level appropriate to the patient is important, especially to ease any anxiety or fears around the procedure, making sure they understand why the procedure is being recommended, why it's important for them to move forward. And then, of course, common theme, enlisting family and social work as needed. And then there are some hurdles to progression for the patient. So a good structural heart program relies heavily on a lot of external departments like radiology, echo, cath lab, and then also outside referrals that we may need to utilize. And each of these departments has their own limitations in terms of staffing or appointment availability. And so there are ways to address that. The other thing to consider is insurance approvals or lack thereof. Both of these things can really hinder a patient's progress toward their intervention, and so you want to address them as quickly and efficiently as possible. Some ideas, if you have the option to use satellite clinics for routine echoes, try to use that as much as you can to limit the burden on your central echo program. Make sure you have open and early communication about staffing needs with the cath lab. Make sure they know well in advance what your schedule is going to look like so they can plan ahead. Partner with radiology and echo to reserve slots, if you can do that, that are scheduled on your clinic days, so you know that you'll at least have some imaging available. And then regarding insurance, the dreaded peer-to-peers and insurance appeals that I'm sure many of us have been involved in. And so in summary, the valve clinic coordinator is a director of patient flow. They ensure no one falls through the cracks and act as a team leader so that the whole team is on the same page. Structural heart programs require multidisciplinary collaboration throughout the patient's course, and the clinic coordinator facilitates that shared decision-making and program growth. And the entire structural heart team plays a role in overcoming hurdles to patient care. That's all I have. Any questions?
Thanks. That was a great talk. I really appreciate that. You know, the clinic coordinators are critical. One question we get asked a lot: what is your staffing? How do you guys staff coordinators for your volumes? What's the appropriate number, do you think?
That's a great question. So I can only speak to our program, but we get about 650 to 700 referrals each year, and I am the only coordinator. Having said that, our nurses play a very strong coordinator role as well, in that they are reviewing our referrals and helping keep the program moving. So arguably, for a program our size, one coordinator with the help of very savvy nurses to make sure all of the patients are flowing through the process.
Okay. Seems like you're doing a lot of work, Jenny.
It's fun work, though.
Good.
Well, and we do 3 APPs for that sort of 700 referral a year volume.
Yes, we have me as the coordinator, and I also have a clinical role. I do about 60% clinical, and then we have space for 2 other APPs running the clinic as well.
Got it.
And 2 to 3 RN coordinators as well.
Okay, thanks everyone. I would like to introduce the next speaker. I have Dr. Matthew Sherwood. He is the co-director of the Structural Heart and Cardiac Cath Lab at Inova Heart and Vascular Institute, and he will be presenting a case study, I believe, on low-risk patients.
Great, thank you very much. Let me see if I can share my screen here, get that kind of going. Let's see. Okay, can everybody see that?
Beautiful.
Okay, there we go. We're started up. So I just wanted to share a couple of cases with good detail, but maybe a little less detail than our first session, in talking about low-risk patients and thinking about the idea of lifetime management as we get into this lower risk profile and how we blend the use of transcatheter techniques, which are rapidly expanding, and be really thoughtful about surgical techniques, which are really still very, very useful and appropriate for the right patients. So we'll go ahead. I just want to remind people, we haven't looked at these yet today, but the guidelines that were released in 2020 by ACC and AHA indicate when you're choosing intervention for SAVR versus TAVR for patients, for example, for a bioprosthetic AVR. So these are patients where you're not going to do a mechanical valve. For those that are symptomatic and are less than the age of 65 or have a life expectancy of greater than 20 years, right now the guidelines indicate it's a 1A recommendation to do SAVR. And for patients who are in that same clinical circumstance, between 65 to 80 years of age, and have no anatomic contraindications to transfemoral TAVR, then either SAVR or TAVR would be recommended, dependent upon shared decision-making and the balance between patient longevity and valve durability. And then clearly those patients who are over the age of 80, although we just saw a great case of a patient over the age of 80 because of medical comorbidities, a really nice surgical case. But in those patients, it seems transfemoral TAVR would be the recommended option. And to buffet that, the idea is that in a 1C recommendation, again, there isn't a great level of evidence here, but it seems very, very reasonable that patients with severe valvular heart disease should be evaluated by a multidisciplinary heart team. I think we've had a very nice kind of example of how a multidisciplinary heart team should be organized by the previous speaker, and then how it should work and how those dynamic plays go together in Dr. Saren's presentation. So really important points there, and I'll get into my first case, and that is we start with a 61-year-old man. He presented to us with dyspnea on exertion, past medical history of coronary artery disease that is opposed to PCI with a single DES, hypertension, hyperlipidemia, and some osteoarthritis, but not a ton of medical problems for this relatively healthy 61-year-old man. He did have surgical AVR for severe bicuspid aortic stenosis done in 2009, and that was done with a 23 Epic St. Jude valve. And right now he has NYHA class 2 symptoms, notices he's slower when he's exercising, doing those kind of things, but he's still very active and wants to work. He's still, on the job. Here's his echocardiogram. And, what we can see is, preserved LV ejection fraction, normal RV, a little bit of LVH, but overall pretty good looking. Peak velocity, 4.2 centimeters per second, mean gradient, 42 millimeters of mercury, AVA 1.0, classic severe aortic stenosis across that bioprosthetic valve. And here you can see the measurements. And then he had a cardiac catheterization going to tell us about how his coronaries are doing since he's had a stent before. Circumflex and looking good. The patent stent in his proximal LAD, minimal disease otherwise. Right coronary also looking good. Doesn't need any revascularization at this time. So given that information, he was presented to our heart team and we calculated an STS prom risk of 1.07%. So clearly, very clearly in the low risk category. But we also want to see, what does our surgeon think when they see them, when they eyeball them, meet them, et cetera. Surgeon opinion, low to intermediate risk for redo surgical AVR and expected to live probably more than 15 years. And you might even say more than 20 years. In addition, he had a CTA that actually showed a 4.3 centimeter aortic aneurysm. And remember, he is a former bicuspid aortic valve patient. So when we talk to the patient, and this is really important on multiple visits with our cardiologist and our cardiac surgeon, the patient emphasized he wanted a good durable valve. He did not want anticoagulation, so he's not a candidate for a mechanical valve per the patient's choice, and that he was fine, honestly, with either Tavr valve and valve or redo surgical aortic valve replacement. And we had several discussions about what that would mean 10 to 15 years from now if he went the Tavr valve and valve route or if he went the redo surgical AVR route. So at this point, I'd like to throw up a poll and kind of see, this is a simpler poll than the last one you saw, and just see what people would choose. Medical therapy alone, I don't think that's the answer for this low risk patient. Tavr valve and valve or redo SAVR. And I'll submit my answer.
Okay, we have a lot still coming through.
No problem, we can wait. Jeopardy music in the background.
Right. Good idea for the next meeting.
So just out of interest, Kenan, at UVA, what do you think you guys would do for this patient? What would be your general opinion?
On this sort of case, I've gone both ways, to be honest. I am not solely convinced by the 4.3 aortic aneurysm that it needs to be handled surgically. He's got no coronary disease, yet he may likely develop more at some other point. I don't know that I think any bridge is burned by attempting valve and valve Tavr here. And I think I would probably guessing this is going to land as a 23 or 26 evolute. And he may still get some good years out of that before he had to go for surgery. I guess one sort of question would be, is he working? What are his goals at 10 to 20 years? Is he looking to retire in the next 5 years and then it's a better time for surgery? I don't know, but I would fight today's battle, and I wouldn't be opposed to valve and valve Tavr as long as he had good. It sounds like this valve lasted a long time, so he didn't have patient prosthesis mismatch that caused early failure or anything like that.
Yeah, great points. Thank you for making those. I mean, really important. I love the idea of we talk to the patient and figure out what's your plan? Like, what do you want out of the next 10 years? What do you expect? We do have patients that don't want to be off work. They're working and they say, I don't want to take 6 weeks off work. I want to keep on working. So they push toward that Tavr route. We do have other patients who want, the most durable thing. So it's kind of both ways. Can we show the results of our survey?
Absolutely. Here we are.
So, I mean, great point. Kenan set it up perfectly, right? 50-50, Tavr valve and valve or redo SAVR. And I think that's about right. And for this case, honestly, for us, it came down to patient shared decision making. What did the patient really want? And eventually the patient talked to both of us, and given all the things that went, the patient actually wanted redo surgery because he wanted to know that the next step that we did when he was 75 or 80 years of age, and nobody knows if you're going to make it to there. You just don't know. But he thought, I'll take a Tavr then, and I'll take a surgery now, and I'll be okay with it. So that's what he got. He's actually scheduled for later this month, surgery. And the question of whether he or not he gets that surgical aortic aneurysm or the aortic aneurysm managed surgically now is a good one. I think if you're undergoing open heart surgery, probably would be managed now. Alan, I see your hand raised.
Thanks, Matt. And I totally understand and respect Kenan's comments. The issue, and I'm not sure that the non-Tavr folks in the meeting sort of understand the differences between a 23 valve, a 25 valve, a 27 valve at the original procedure. A 23 prosthesis, which this guy has, is sort of the lower limits where a valve and valve can be done. And so if you consider what you're teeing up for your next procedure, it is unlikely that he could have a second valve and valve procedure. And so at his age now, with a good longevity and is a low surgical risk for redo procedure, absent is any coronary disease, replacing his valve, he got 15 years. He was done in 2008 or 2005.
It was like 13 years. Yeah,
so he got so 13 years. He'll be in his mid 70s, where a valve and valve at that time would preclude his second or third open heart procedure, or second open heart procedure, yet at a later age. If he had a 27 or 29 valve, I think it's arguable, could he have a second valve and valve? That would take us down that rabbit hole. But secondly, since he had a bicuspid valve to begin with, recognizing that the aortic dimensions are only 4.3, if I was doing him now, I would do the replace the aorta at 4.3, but that would totally in the future mitigate any potential of having a failed valve and valve. But oh, by the way, the aorta is now 5 or 4.8, something like that. So I think that the original prosthetic size goes into some of these decisions in addition to the patient themselves, their wishes, age, comorbidities, all that.
Yeah, I think that's totally fair. The only other thing I'd add is that when I've done the redos on a valve and valve, it's a little bit easier than when you do it just on a primary Tavr that doesn't have a sewing ring around it. Like, I think the Tavr explant is a lot easier for when it's a failed valve and valve. But he would be 10 years older potentially when you tackle that aneurysm surgery, as Alan said, along with the redo Tavr.
And I'll just mention that it's always interesting to think about. We don't know what we're going to have 10 to 15 years from now. So if we did a Tavr valve and valve now, and we start to worry about what can we do 10 to 15 years from now, we may have really, really nice solutions for this 10 to 15 years from now, but we don't know. We just don't understand limitations. And I tell you, limitations of TAV and TAV are just coming to light now, and we're starting to tackle them. But it's an interesting question that we don't have the answer to. I think I heard Paul speaking. Go ahead.
Yeah, I was just gonna, it's interesting. Our topics dovetail a little bit. I'm gonna have a little bit of data on surgical survival after this. I would have argued for a TAVR and a biological valve fracture in this patient. But I don't know if that's necessarily any better than your plan. It's in that 50-50 range, but this is a pretty hot topic. I'm going to talk about it a little bit more. So keep this case in mind when we go through in the next one. And I may have a little bit of data for you.
That's great. That's great setup. So let's talk about one more case. Case number 2, 56-year-old woman presents with a dyspnea on exertion after a STEMI 6 months ago. So at that time, she got a DES, PCI to her LAD with a DES. She also has hypertension, hyperlipidemia, diabetes. Her STEMI was bad enough that she actually had an LV thrombus, and she had to take warfarin for 3 months, and that resolved. But she also had morbid obesity, and she's a larger lady. Her BMI is 45. She's 302 pounds, in the lower end of the 5-foot range. She's not tremendously physically active. And oh, by the way, she now has severe aortic stenosis. So echocardiogram, LVEF preserved again at 57%, peak velocity 3.8, mean gradient 37, but AVA 0.6 centimeters squared, calcified valve, mild LVH. And she also has, the valve isn't very healthy. It's mild to moderate AI as well. So here are the measurements for that. And then Cardiac catheterization wise, went ahead and checked it out. Those stents in the LAD still looking good, thankfully. And on the right side, you know, still reasonable, mild disease, nothing major. And again, presented to our heart team, STS predicted risk of mortality score 1.59%, mostly driven by the fact that she's 56. So if for those of you that calculate STSs, almost all of it is the primary number is based on age. And then you just add things to it. So at 56, you start with this primary number that's like less than 0.5%. And then even as you add these other comorbidities, it's really hard to drive that STS risk score up. It's very, very heavily weighted on age. So in the low risk range. Surgical opinion, though, was that she's clearly high risk for surgical AVR due to her body habitus and medical comorbidities. And then back and forth with the interventional cardiologist, TAVR access could be problematic because this lady is really heavy, and the access transfemorally might be very difficult, may not heal as well, et cetera. Whether or not there's increased risk of vascular complications, which are tough to get with and do increase the likelihood of mortality. Those are things to talk about. In addition, because of her having a STEMI as a woman at 56, and with all these other medical comorbidities, we didn't know how long she's likely to live. I mean, I guess actuarial data might suggest she might live another 10 years, but looking at her, she's not so active. She has multiple medical problems. I don't know if she's going to live another 10 years. Patient is against surgery at this time, doesn't love the idea of surgery. Surgeon stated, we'll do whatever she needs, but we would do TAVR now. If she needs surgery, we'd do it when she's 65 or 70, et cetera. So what would people do with this 56-year-old woman? Same options. And now I'll pick on Paul and ask him what he would do with a 56-year-old lady with these kind of problems. You have a really high volume program. You see this all the time. What do you think?
We do. I think this one, she's 56, but she ain't going to be 76. She's got a lot of high risk features, known coronary disease. And so there, I don't know if we can definitely say she has a 20-year survival. So the 56, 65 thing goes out the window. She does have a chance to improve some of her issues, such as her morbid obesity. But I think you take care of the patient in front of you today, and her best chance for a meaningful quality of life over the next 10 years is probably going to be with TAVR. We're not too worried about access in somebody this big. We're all living in the state of Virginia. We deal with BMIs of 50 all the time. And I think she can get a TAVR valve, hopefully find some religion on taking care of herself, and then follow her that way. Her recovery after surgery, she'd probably survive the surgery, but she'd have probably a pretty rocky recovery, I would think, from that. So we would proceed with TAVR and with this patient.
Alan, what do you think about surgery in people like, who have these medical comorbidities, who might be this heavy, et cetera?
I don't agree with the risk score. I think there's so many more intangibles that we don't capture through the STS, despite the further refinements. And our database managers are much more adept at that than I. So what you've described is totally incongruous. That the first two bullets don't trap. So I think that the patient being against surgery, let's take that out. Let's just say she would go along with whatever we recommended to her. With her BMI at 50, I think you said, is that right?
It's 45, yeah.
Okay, 45. And given the coronary disease and her expected survival and the increased risk, I think that, as Paul just said, an alternative mechanism of access through the carotid or whatever, treat the valve disease and then see. We always say, well, maybe she'll get religion, maybe she'll lose weight. I personally, in some years, have really never seen that to be the case. If anything, they gain weight. So it's not like they'll go out and all of a sudden think I'm going to lose, 100 pounds in this setting. Some do that, but that haven't been operated on and are doing it for other reasons. But it would be unlikely for this.
Hey,
Thank
Matt,
you. Perfect.
I just
Oh,
want
yeah,
to
go
throw
ahead.
one more thing, because as a lady that I met, and I think, for the surgeons on the call, they'll appreciate it. She had a really small root, and that was going to be the other issue, was that, even with aggressive annual enlargement or even a root replacement, I mean, which I wouldn't want to do in a really short, squat woman with a deep chest, but she was going to end up with probably a smallish valve. So one of the other considerations was really to maximize her EOA. I thought Tavr was going to be her best shot. And then, if she comes back in 10 or 15 years, hopefully I'm retired, or I can send her to Kenan.
I definitely agree that those anatomies in the morbid obese patients with a small STJ, I do think like a self-expanding Tavr valve makes a lot of sense. And I also agree with Alan and Paul's point about alternative access in some of these morbidly obese patients. I find a carotid cut down almost the simplest thing, avoids any groin complication, particularly as you approach BMIs of 55 or so. We've certainly done that a number of times.
Well, it's great. Thank you very much, you guys, for your comments. The poll of the audience kind of agrees in that 2/3 for the Tavr, 20% surgery. Given her age, we didn't think medical therapy was reasonable for this lady, so we went ahead and treated her. And we did plan on Tavr. So we did a CTA, as Eric has mentioned, small root size, area 403, perimeter 71.8. Lowish, left coronary, but not terrible, kind of in the 8.6 range, 21.8 on the right, normal kind of angle for her root. But you can see that the root is small and kind of has an effaced kind of structure, doesn't have big sinuses or anything. And then access was okay. I mean, no major PAD, bifurcations were low, so that helped us, et cetera. So we went forward with this transcatheter valve replacement. And I'll show you, the reason I'm showing you this access picture is we did decide to do transfemoral. And, it's not as much to show that we can, put the access in the right place, but to show you that the shadow shows you how large this was and how much we had to work to get this access in the right place. So it was difficult, but we did get good access in the right place. And went ahead and performed a 26 Evolut R implant. She had a pretty nice result, honestly. She ended up with kind of trace paravalvular regurgitation, but really high, nice resulting valve. Everything looked great afterward. And then looking at the echo, really nice normal LV and RV function, almost no paravalvular leak, and looked good. Went home the next day and did well. And we did counsel her significantly on weight loss, et cetera. But the conclusion of these cases, and I really want to thank everybody for contributing, is that STS risk scores are useful, but they're honestly limited. And I think Alan pointed this out. They don't take into account, honestly eyeballing the patient and looking at them more significantly, and they're very, very biased toward age. The heart team approach is guideline director, and it's also vital to optimizing patient care and making the right decisions in a contemporary valve program. And then shared decision-making is critically important. You have to take into account the patients and their considerations of what they want to do. I think Kenan brought that up very well earlier, and consideration of lifetime management. So thank you very much for your attention. And I know we're gonna send it over to Paul next.
All right. So I have a similar talk that I've been asked to give on sort of valve selection and lifetime management. Dr. Sherwood did a great job showing a couple of cases. I'm going to take it a little bit deeper and talk about sort of the philosophy and the pros and cons of which valve to select. So if you're okay with me sharing my screen, let me get set up here. Get the right talk. Good. You guys see that?
Not yet, sir.
Not yet.
Okay. I was thinking, oh, I got to hit the share button. It's complicated. All right. How about now?
Looks beautiful.
Okay. So lifetime management of aortic stenosis. Let me get into a speaker presentation mode here if I can. Great. So first of all, greetings from the southeastern part of the state. I appreciate the opportunity to speak to this great group, and greetings from Norfolk. Some cautionary tales. I'll start off with a couple of quick cases. and talk about the future comes pretty quickly in Tavr and talk about lifetime management. We have a 53-year-old female who came in long-standing hemodialysis patient, severe symptomatic prosthetic aortic stenosis with a Vmax of 525 when she came in. She had a surgical valve in 2010. She had a 19 Magna, pretty small valve. She came back 5 years later, again, on dialysis the whole time with a failed surgical valve, and she underwent a 23 core valve implantation. After a heart team discussion. This predated basilica and fracking, so that was not done. This wasn't being offered in 2015. And we placed it low because at the time we were worried about the risk of coronary obstruction and sequestration in a small route in a fairly small patient. Her SDS when she came back this time was 17.5, and she's diabetic and a BMI of 17, a very small lady. And she was referred for valve, in valve, in valve. So you can see that we have a Evolut valve inside a surgical valve, and we're placing a sapien valve inside of it. We place a sapien valve, we place it intentionally low because there's a risk of coronary obstruction. And then we took a high pressure true balloon and we fracked that, and we ended up getting her gradients down to 4. So this isn't so much a theoretical concern as a kind of, we're all going to be dealing with this sooner rather than later. I'll show you a second case of a failed Tavr valve. This is an 80-year-old female. In 2013, we placed a 23 sapien XT. She has COPD and frailty at the time, but she is high risk indication only. She did very well. She came back 9 years later with dyspnea, fatigue, and a Vmax of 550 with severe calcific prosthetic valve aortic stenosis, STS of 12. Coronary angiogram was concerning, as you guys can see. The left main takes off below the level of the frame. So to place a new valve inside this valve, the risk of coronary obstruction in this patient was felt to be quite high. You can see on the CT scan that the Tavr valve, the original Tavr valve, comes up over the ostium of the coronaries, and the VTC on the left was 2.7. That's valve to coronary distance. On the right, it was 3.9. The VTSTJ, which is how close the valve comes to the sinotubular junction, was 0. The right VTSTJ was 3.3. So the right was felt to be okay, but the left was at extremely high risk of obstruction. She was not considered a surgical patient, so explanting this valve didn't seem to be a reasonable choice. So we did a balloon-assisted basilica and valve in this patient. We decided to create enough room in the coronary sinus to pressurize the coronary sinus and pressurize it. And you can see from this very sophisticated iPhone picture, we inject dye into it to show where that is. We lacerate the leaflet with a balloon, and then we tear that leaflet. And the purpose of this, now this patient luckily had commissural alignment. This was random. You can't predict this with the sapien valve. And then we placed a Evolut valve inside of that. I will say that everything we're doing in this case is off-label, but just to demonstrate that these patients are out there, these problems exist, and we're all going to be dealing with these in the relatively short term, if not already. So it begs the question, for when you're looking at a patient, Dr. Sherwood showed a couple of great cases. For you, and you know, I'm old enough, maybe if I get 10 years out of this, maybe I won't be around, but some of you younger guys are going to have to deal with this. For young, low-risk patients with aortic stenosis, how do we pick the first valve? Patients being considered for Tavr versus Tavr changed dramatically. This is Mick Jagger underwent Tavr a couple of years ago. This was 3 weeks after his Tavr, preparing for his concert. And everybody wants to move like Jagger. He's 75, by the way, and that's to shame everybody. Lifetime management of patients with aortic stenosis. So the changing risk profile of the Tavr patients in the TV and the STS registry. The median age has gone down from 84 to 80 over a 6-year period, and it's continuing to fall as we treat more and more patients. So the patients are getting younger. The amount of Tavr being performed is getting more and more. Isolated Savr was superseded by Tavr in 2015, and then in 2018, all types of Savr were exceeded by Tavr. It's the dominant form of valve replacement in patients with aortic stenosis. So when you look at this, you have to ask yourself the question when you're sitting in front of a patient, what do low-risk AS patients want? Well, they want what we all want. They want us to fix the problem. That's what I would want. That's what you would want. You want to fix the valve effectively. You want the lowest risk of death or complication and the least disruption of normal life. And Captain Obvious is here to help us with that. But there's secondary discussions you got to worry about. And this is what the patients don't think about, but we need to discuss the durability, and we'll talk about that, functional status, and then freedom from device-associated complications, pacemakers, short-term coronary access, and long-term valve and valve suitability. So in terms of fixing the problem, the jury is not out on this anymore. The PARTNER 3 and Evolut low risk showed that with an endpoint of death, stroke, or rehospitalization, it favored Tavr. at the 1 and 2 year mark, and this led to approval for all risk comers with Tavr. So Tavr suitability and low risk has really changed the conversation. The concept of surgical risk, we talked a lot about how increasingly anachronistic the STS number is. The surgeons don't really trust it, we don't really trust it, and it's an outdated concept. Instead of considering surgical risk in the Tavr population, consider Tavr suitability. So when is Tavr more suitable than Tavr? What patient-specific factors lead to favoring surgery or catheter-based valve replacement in low-risk patients, and optimize a treatment strategy to the patient in front of you? Here's 2 surgical low-risk patients. Matt did a great job showing these. I'm not going to labor it. Patient A, 74-year-old, no prior surgery, primary caretaker of her husband with dementia. That should be Tavr all day long. But patient B with a 59-year-old diabetic with an elevated creatinine, low coronary heights, and ascending aortic aneurysm has surgical anatomy. Tavr is not the right choice for that patient. So individualize the approach. So who does well with Tavr? When you look at this, any risk, okay? If you have calcific aortic stenosis, you do well with Tavr. Some bicuspid valves probably don't do as well, and they were excluded from the low-risk trial. You need to have an acceptable aortic valvular complex. You need to have the annulus size well matched to your valve. You need to avoid patient prosthesis mismatch. You need to look at calcium patterns, and you need to look to see if there's any ascending aortic pathology. All of the advantage in Tavr is concentrated in percutaneous femoral access. Once you start doing alternative access, the benefit of Tavr over SAVR is no longer present. So that's individualized. If it's a percutaneous femoral access, then it's better. But if not, then you have to look at the patient. And then the absence of unfavorable anatomies. If they have surgical disease or multivessel disease, then they're probably best suited with Tavr, with the surgery, I'm sorry. So what makes Tavr less favorable? Targeting SAVR, what low-risk patients should be operated on? Hostile aortic root complex, low coronary heights, narrow sinuses, enlarged annuluses, lack of transfemoral access, concomitant surgical CAD, and then patient's age and durability. Although I'm going to argue that this is far less favoring in surgery than most of the literature suggests, or most of the guidelines suggests. So let's talk about some of these patterns. Low coronary heights. This is a high-risk patient we did a few years back. Again, very sophisticated iPhone picture. But you can see we put a sapien valve in, and you can see this ball of calcium pivoted towards the left main. This is potentially catastrophic. If this was a lower-risk patient, you could identify this on the CT, avoid this. We ended up having to stent out from the left main for this patient. The patient did fine. But if this was a low-risk patient, I wouldn't want to know what the 20-year patency of this complex would be. Hostile calcification patterns. You see that there's a high risk of LVOT obstruction. There's LVOT calcification, which is a high risk of annular rupture. You're higher risk of paravalvular leak. Maybe surgery is better for this patient. For large annuli or unfavorable calcification, if you can't get mild PVL or less, then you have a survival disadvantage, and then maybe your low-risk patient is not better suited with the catheter-based therapy if you can't eliminate PVL. So very large annuluses outside of the range of the Tavr valves should consider surgery. Okay. Now here's the one I think that gets thrown around a lot. Should patients' age and valve durability be a significant consideration in low-risk patients? Well, let's first consider how durable SAVR prosthesis in low-risk patients are. I'll show some slides on this. From the Danny DeVere registry, the Valve and Valve Vivid registry, the median age of SAVR prosthesis undergoing a valve and valve procedure is 8 to 9 years. So we are replacing valves at 8 to 9 years is the most common one. All right, not the 15 years that we used to talk about. So when we talk about surgical or transcatheter valve selection for AVR, life expectancy is the key metric for valve selection, some say. So here's a nice graphic from a paper from the European Heart Journal that showed SAVR shows a survival benefit, valve durability, avoid pacemaker, annular enlargement. Some of the factors favoring some are SAVR, some favoring Tavr, and then in the middle, when this 10 to 20 year, it's a shared decision-making with patient preferences and values. And the authors feel that valve durability favors SAVR over Tavr. Well, let's look at that. Okay. Here are the guidelines. Dr. Sherwood did a nice job showing them. AHA says if you're less than 65, you should have surgery. Your European guidelines say less than 75, but there's lawyers involved, so there's always a wiggle room. If your life expectancy is greater than 20 years, you have the surgical AVR. Very few of us have crystal balls that can see the patient in front of us will definitely last more than 20 years, and we have some data to look at surgical patients. Okay, So if you take patients that have a surgical valve replacement and you stratify them by risk groups and you look at survival, these are patients who had a surgical valve replacement divided to high, intermediate, or low risk. The 50% mortality rate in a high risk patient is less than 6 years, and the intermediate risk patient between 7 and 8 years, and low risk patients between 10 and 12 years. So really outside of a low risk patient population, they're probably going to get one valve in their lifetime. All right. If you look at just the low risk patients in the Sweetheart trial, it's a great name. They stratified them into 70, 75, and 80-year-old risk. And only the patients 70 or 75 had a median survival over 10 years. When they looked at the group 60 to 64 years of age, the median survival was 16.2 years. So we're not looking at 25, 30 years survival. We're looking at 16.2 years. And can you get with 2 TAVRs, can you get to 16.2 years in the patient? That's a question we can answer. Also, and this is a bit paradoxical, but the younger the patient is, the faster they chew through a tissue surgical valve. And this has been well documented. Younger patients have a higher risk for surgical explantation, and the cumulative risk of surgical valve deterioration is highest in patients under 60 years and markedly accelerates 10 years after SAVR. So the youngest patients, when we want to get the longest run out of a SAVR, tend to chew through their valve the fastest and have surgical valve deterioration earlier. Hemodynamic performance. If you look at the randomized clinical trials, looking at TAVR versus SAVR, the hemodynamics were better and persistently better out to 5 years, TAVR versus SAVR. If structural valve deterioration is a function of hemodynamic performance, then the TAVR valves tend to outperform the surgical valves. Hemodynamic valve deterioration out to 5 years after valve replacement, randomized clinical trials, was higher in the surgical group at 5.9% at 5 years versus 2.7% in the TAVR group. Notion 8-year outcomes, TAVR versus SAVR. Again, hemodynamics favored the core valve. This was a core valve versus surgery comparison. And we looked at structural valve deterioration at 8 years. It was almost 30% in the surgical arm and 13% in the TAVR arm. So durability is not necessarily favoring a surgical valve, according to the data that we have. So lifetime management, here's a nice graph showing if the TAVR durability, if you estimate 10 years, most of these patients, even most of the low risk patients, you can probably do 2 TAVR procedures and take care of the majority of the population. Okay. So let's look at low risk TAVR patients. We're not talking about surgical versus TAVR valves. What's the ideal TAVR valve? You now have a patient in front of you that you need to put essentially a sapien, a core valve, or now potentially a portico in. So what is the ideal TAVR prosthesis? You need the lowest procedural risk. You need the best hemodynamics. You need the lowest pacemaker rates. You need the least interference with coronary access. You need the most durable and the most suitable for TAV and TAV in the future. I will tell you right now that this is a unicorn I'm describing because the ideal TAVR prosthesis does not yet exist. Okay. Which one should you pick? Well, there's a lot of talk back and forth about pressure recovery and patient prosthesis mismatch. I would say that the data states that you really need to avoid severe patient prosthesis mismatch. You can say what you want about pressure recovery, but do not knowingly give your patient severe PPM. The surgical and the TAVR literature strongly suggest a decrement in survival very quickly if you do that. How can we avoid that? All the valves have these nice charts that are provided that show us where you get mild, moderate, and severe PPM. You can look at the charts for every patient. We do this in our clinic. It's part of our standard reporting, and we avoid severe PPM whenever possible. You can also plan ahead. The best way to avoid a TAV and TAV complication is to maximize durability. So do a good implant with the lowest rate of stroke or complication. Pay attention to your hemodynamics, your effective orifice area, and avoid pacemakers. Can we predict coronary obstruction with the second Tavr with the first CT? Can you look at it, put a virtual valve in there and plan for the second implant with the first implant? You can. And it varies patient to patient, but you can do virtual valve simulations. For a patient, you can do a 20 millimeter virtual valve versus a 23 virtual valve. On the left would be an Evolut, on the right would be a sapien, for example, in this patient. And you can predict what the VTC will be on the second go around. You can look at the coronary heights, you can look at where the valves implant, and you can start thinking about the second valve when you put the first one in. And there's no one that's clearly favored in this. We're also starting to see a lot of really important work done on how do you plan for the second valve. Here's a recent paper just published in the last couple of weeks, basically looking at placing a sapien valve inside a degenerated Evolut valve and showing you where to implant it in terms of risk of leaflet overhang and hemodynamics, and telling us which node to place that valve at. So as we move further and further in this, further science is going to help us take care of these patients down the road. So if you're faced with that nice patient that we just saw that at 60 got an evolute valve and she comes back, we have some guidance on how to handle that. We also have a lot of novel techniques. I showed you a basilica technique. We do a lot of basilica at our center to modify that. And I can only assume that the technology will keep up and we'll have some new and novel ways to help mitigate the risk of coronary obstruction. So in conclusion, for all but the youngest low-risk patients, I would argue the initial valve should be a Tavr valve optimized for the patient. Make sure you have appropriate anatomy, procedural safety, good hemodynamics, appropriate access for the coronaries, have a second valve strategy prepared, a clear discussion with the patient regarding the need for a second procedure, and wait for new strategies to deal with complex situations. But when in doubt, the next 10 to 12 years matter. Take care of the patient today. SAVR should be the first valve choice when the anatomy is unfavorable for TAVR, when there's concomitant pathology present that favors surgery, CAD or aortic enlargement, and when the surgical risk is acceptable. All right, so that is all that I have. And I'd be happy to, it's a little bit controversial on purpose, just to provoke discussion. So I'd be happy to have some discussion on that.
Paul, this is Alan Spear. There's thank you very much for being with us this evening. We've certainly heard a great deal about your great results in your program there. So it's nice to sort of see this firsthand, and appreciate your overview. I think it's from the surgical perspective, given the mantra that we don't want to be putting in valves less than 23 millimeters, we're much more aggressive on annular enlargement and upsizing every way we can. You led off your talk, though, with sort of just a right in your face sort of case with a 19 millimeter surgical valve that you then put a not one, but two Tavrs in that. And I have to say that over our mantra in the early Tavr days, the concept of a valve in valve at a 19 was a reach. And so is that a standard practice for you? Is that, what is the valve size that you feel that a valve in valve would not be appropriate?
Well, that's a great question. That case was an unusual case of a very small woman on dialysis who was not a surgical candidate in 2015. And so we did the best we could with the core valve. That was before techniques such as fracking or basilica existed. So the surgeons were not willing to touch that patient. And then 6 years later, she was no better. She's done very well. She's lived a long time in hemodialysis, so you never know. We don't have a minimum size. We do a lot of fracking, biological valve fracking. For those that you don't know, you take a high pressure balloon, you actually crack the surgical frame, and you can increase the size of the surgical valve. So you can make a 19 valve with a gradient of 25 into a 19 valve with a gradient of 4 or 5, and we do that routinely. And we can modify the leaflets. So if she had been a surgical candidate, that might have been a different discussion. It's the first case we've done with a valve in that setting. So I thought it was interesting that these patients are out there. But we had a run of 19 millimeter magnas about 10 years ago, and we've treated a lot of them. We've gotten very good hemodynamic results with fracturing those valves. So we don't have a lower limit for valve in valve because of the ability to frac the valve.
How many valves that you have sought to enlarge with the balloon techniques have ruptured?
None so far, but there are isolated cases of VSD and angular rupture. Knock on wood, we size them pretty carefully. It's 3 millimeters larger than the true ID of the valve, and we have not seen that. We've had one small VSD that was hemodynamically well tolerated, but we've not had angular rupture.
Thank you. Nice job.
I think it's certainly an interesting concept about which valve should go first. And to your point, I think that the anatomic considerations of the patient probably weigh in more than the surgical risk as to how appropriate TAVR is for somebody. The issue is, comes to bear is that a lot of the patient population below the age of 65 is usually a bicuspid or heavily calcified anatomy. And certainly in those patients, my bias is strongly towards surgery if they're low surgical risk, just given in my mind, like you said, I think the anatomic considerations there weigh heavily on my mind in terms of what their lifetime management might be. But I agree. I do think anatomic considerations rather than STS is a better way to evaluate patients.
Yeah, it's the larger bicuspids in the younger patients. You know, a good surgical valve replacement is hard to argue with.
Right. If you can get in a 27 valve and you know, you debulk a heavily calcified raphe, then I think you'll end up with a better result. But, you know, for the, you know, sort of 65-year-old who has trileaflet anatomy, no aneurysm, I agree. I think there's much more of a debate to be had about whether or not the guidelines are appropriate as written.
Yeah, the nice thing in the guidelines, they do allow us to have some wiggle room with the 20-year mark. So 65 is not written in stone. It's what you think the longevity of the patient in front of you is. It becomes a point of contention because people just see that number.
The other thing is always the pacemaker rate, which we've made a huge dent on, but it certainly is not an insignificant consideration. Depending on their EKG and the distribution of their calcium in that age population. Because that's another thing where you really have to not take a gamble to putting a pacer in somebody at age 60 is way different than 80. And then I agree with you there.
Yeah, without question. And that's why it's incumbent on the Tavr operators to be able to get single-digit pacemaker rates. You know, surgical pacemaker rates are about anywhere from 3 or 4%, and that's the number we got to try to mimic. Because if you're doing a 20% pacemaker rate, you're not doing the population a service. So, I would agree. Okay.
Kenan, can you comment if you guys agree on the minimum valve size when you have a patient that's moving into surgery? Do you guys agree beforehand what the minimum valve size, and if not, you know, do you move to root enlargement or something else?
Surgically?
Correct, yes. When you have a surgical patient going from the structural discussion, do you guys have a discussion about which valve type, valve size, and kind of a game plan, or how do you handle that?
Yeah, we do. We at our program, most operators would shoot for a 23 tissue valve unless there were compelling reasons not to enlarge the root. Certainly in redo settings, I might, if I really felt like their first valve failed early, you know, we have an active discussion about whether, you know, a redo AVR with an annular enlargement versus just a biobental at the time of the redo is more appropriate. And that's certainly an evolving thought process. But most people are shooting for valve sizes of 23 or greater. And we're certainly looking at the charts. I personally feel like the industry charts, when you look across companies, they're designed to look certain ways. So I really think about the patient in front of me and what gradient would be acceptable post-op for that particular patient, how active that patient's going to be. But I definitely am curious other surgeons' thoughts on that. I mean, there's some patients where I think a mechanical 21 or 19, if they're small, you know, and that's their anatomy, then that might be acceptable, but it depends on the situation in my mind. Certainly want to open that up to other surgeons.
Yeah, I would agree with that. I mean, for us here, you know, when we're taking someone to the OR, I don't know that we ever have sort of, you know, we never really will set out at the beginning and say, well, this is the valve size we're going to put in. But as Kenan said, I mean, I think we're all pretty hard pressed to settle for anything less than a 23. And then for a young, especially a male, you know, that's a larger, you know, size person. I mean, I've enlarged annuli to go from 25 to 27 or even 27 to 29. You know, I think if you're comfortable doing the procedure, which I was very fortunate that Dr. Spear taught me how to do an annual enlargement when I was fresh out, that it's reproducible, it's safe. In my mind, there's no reason not to do it. And so I would say on my open AVRs now for the last 8 years, I have done annual enlargements on more than half of them when I'm putting a tissue valve in. And it doesn't matter. Like, I mean, even if I size for a 23, 25 right off the bat, if I'm thinking down the road about a subsequent Tavr and I really want to optimize hemodynamics, which is the whole point, then I'm going to enlarge the annulus.
I'll say one other thing now that a lot of the patient population has shifted to Tavr, the ones, you know, that are left over in their 55 to 65 range. I have had a more open mind to mechanical replacement than I used to.
Yeah, one of the discussions we have is not surgical valve versus a Tavr valve. It's mechanical surgical valve versus a Tavr, you know, in terms of talking to the patient in the younger age bracket and explaining to them a single surgery with the mechanical valve is an option for them. The people are a little frightened of Coumadin, and a lot of people are not willing to do that. But for some patients, that's a good option.
I tell you, I think that this remains the elephant in the room because it depends on the locale you're in. Some manage Coumadin very well. We've had mixed results with that because it's deferred often to the internal medicine groups. Without a true, the military probably does the best with Coumadin management because they're all over that. But you know, when you're looking at 2 to 3% per year of a Coumadin associated problem, at 10 years, you've got, I mean, do the math. Yep. And so putting a 19 mechanical valve in it doesn't bode well because now you've come back either with a Coumadin associated problem or PANIS that doesn't take much to encumber one of those leaflets. And now what do you do with a redo 19 mechanical valve? And, you know, that's going to often be a total root. And now you're getting into the septum and those types of techniques that aren't the simple annular enlargements with the patch reconstructions. Thankfully, those are few and far between, but in communities that have a high Asian population, these smaller Vietnamese females, this is a very consistent presentation with them, and the Chinese as well. So I think that by default, almost the Tavrs and are going to be more and more appropriate in that setting, in my opinion.
Yeah, my least favorite operation is a redo with a 19 valve in place because it means I'm going to have to do a total root probably. Well, great. Am I next?
Yeah, go ahead.
I think Dr. Yount is next.
All right. All right, so my talk is on the surgeon's role in the heart team, and this continues to evolve. I think we've gotten some clarity over the years over where the surgeon's role should be in the heart team. Just to provide my background, I did an integrated cardiac surgery residency, so I did not do general surgery, and I had sort of more of a cardiology approach and well integrated into my residency. I also did a structural cardiology fellowship for 1 year with Dr. Lim and Dr. Alawadi. And then I spent 3 months at Penn learning minimally invasive valve surgery from Clark Hargrove. Recently, I sort of did a lit review on this, and this sort of came across an interesting article, which was the train is left, can surgeons still get a ticket to treat structural heart disease? And in Europe, they have published that the absence of an on-site surgeon and surgical team did not increase Tavr mortality or morbidity, which certainly is controversial. We haven't gone that route in the US. But when people publish things like that, then the obvious questions become, is surgical backup necessary? Or will history repeat itself in eliminating surgeon involvement in certain procedures, as was the case in PCI several decades ago? And it's just always interesting to see the waves and tides over the decades, how we shift back and forth on these things. And also sort of recognizing the increasing role of structural heart interventions. Another recent article proposed, these guidelines haven't been accepted by the board, but you can see that some people feel pretty strongly about structural heart training for surgeons, with sort of sample proposals being requiring 50 demonstrated competencies of doing a CT scan, aortic root analysis, and sizing a valve, and then a number of cases as primary and secondary operator. And I think these are appropriate questions to be asking and things maybe to be demanding of surgical training as it looks towards the future. Just my own perspective as the surgeon's role, and where this fits in is they're really not just there to assess clinical risk. I think you have to assess what the likely outcome of surgery is in light of the patient's goals of care, and then also weigh in on technical challenges that might complicate open surgery, whether they be anatomic or comorbidities that aren't accounted for in risk models. I think it is all fair game that the surgeon needs to weigh in on, particularly if you're talking about redo AVR, there are grafts and unfavorable locations that are patent. What will the redo entry be like? What will the surgical outcome be? Are you really looking at a redo AVR? Are you looking at a redo root replacement or an annular enlargement? I also think it's incumbent on surgeons to have a mastery of the imaging, not to rely on industry to size these things, not to rely on their cardiologist or radiologist to reconstruct the CT scan for them. I feel like it's pretty strongly indicated for the surgeon to be able to do those things and at least interpret it. And then when it comes to mitral intervention, same thing goes with TE and the structural heart CTs there. I think surgeons also are incumbent to guide access, technique, and closure. Certainly there's continuing acceptance of alternative access, and also different techniques in percutaneous closure. And certainly that's come out recently in sort of how surgeons feel about certain closure techniques, be they perclose, manta, what have you. And I think a surgeon's role in really evaluating what those closure techniques are critical. And then finally, I think obviously you have to be able to manage complications and finally be a team player and view everybody as equally important on the team. So my bias based on all that then would be, I strongly feel that decision-making and outcomes are better when the cardiologists and surgeons work together. And I think when you're building a heart program, the incentives thus need to be aligned institutionally, where everybody is encouraged to be part of shared decision-making, and that the program metrics dominate, not just individual practitioners' metrics. And I think that's true of not just Tavr, but mitral disease, tricuspid disease, other sort of rarer or less common conditions like hypertrophic cardiomyopathy. Certainly it's been true in heart failure that heart failure cardiologists and transplant surgeons work closely together to get better outcomes. And I think what Tavr has shown in terms of the heart team has come back into the coronary disease debate, because here it's pressed us to develop an advanced coronary team. And certainly my joint clinics and valve, I sort of do the same thing with our interventional cardiologist, where we get patients who are on the fence between PCI and CABG. And I think the collaboration we've seen in Tavr has fostered that collaboration in coronary treatment as well. So with that, I have some cases in mind. Everybody else presented their great cases. I have more of a mixed bag, so I think it's more interesting that way. So case one is a 63-year-old male, severe symptomatic AS, low risk surgically. STS was about 1% or less. He had good femoral access, not many comorbidities. Soon to retire, but works for a utility company, does get up on ladders and different things. Had no coronary disease, good function. Obviously, you can see pretty impressive, but not unreasonable mean gradient and peak velocity. Here was his valve morphology. You can see it's the Sievers type 1 with a bit of a calcified raphe. Certainly a lot of bulky calcium here among the non-coronary. Is ascending, technically below guidelines, but you can see he's walking it pretty fine. certainly if surgery were in play here, I think surgeon, I don't know, I'd be interested to see, I didn't do a poll on this, but whether or not surgeons would replace it, I think he's pretty much at the threshold if he were to have open surgery myself. And just to sort of add to that, I think some things that I do when I'm making that decision is I look at the aneurysm size relative to the rest of the anatomy. And there you can see it's pretty prominent. So let's do a poll here. What would people do? And this patient comes to you pretty much wanting to have Tavr and move on with his retirement.
Okay, we're slowing down. A few are still coming through. Okay, we're at a 48% response rate, and here are the results.
Wow, 50-50. Well, I certainly offered him surgery and strongly recommended surgery. But it's certainly an interesting debate. So, I'd say in summary, I thought he was a low risk bicuspid surgically with a reasonably horizontal aorta, and he had this on the border aneurysm. He was very reluctant with shopping around and finally sort of twisted our arm on Tavr. So we did a PERC right transfemoral 26S3. This was before we had really a 3-Mencio program for our for how we sized Tavr valves and also how we predicted angles. Here was his valve deployment, and you can see it's a very horizontal aorta, and I'll let it run. And clearly too low, but it rode up. And there it is, in place, a lot of parallax, the angle is wrong. And I don't think we would have done this. This was probably 4 years ago. Post-deployment. Well, it's not filling the root, but you can see the calcium from where the annulus should be is way up here, and the pigtail's right here, and there's the valve down in the ventricle. So what would you do for this patient? I forgot to put a poll up here, but this was the real crux of this case, is in terms of the surgeon's role here. You've got a complication. How are you going to manage it? Would you deploy another valve and stabilize that in the LV in a slow risk patient? And then how would you manage it if conversely the valve had gone into the ascending aorta? Would you try to handle that endovascularly? Or is it just time to open on this low risk patient and get a result? I'll let people weigh in for a second.
Yeah, I'm happy to go first. I mean, at this point, I would convert to open. I mean, I think that in a low risk guy, this is, I think, germane to Dr. Mahoney's talk. I mean, you're shooting for a perfect result. You didn't get it. You have the opportunity to salvage it, I think, and give him a perfect surgical result. I think you start chasing your tail a little bit when you start trying to land valves high or low, extend your seal zone, things like that. And the young guy, that's going to affect your durability. I think, before things get too out of hand, this is a patient that I think here we would convert and open them up.
Yeah, and embolization above the annulus, you've got a fighting chance with endovascular techniques, but in the ventricle, I would agree with Dr. Sarin. We would almost certainly open this patient.
Kenan, the way I would have asked the question is, who wouldn't open him up?
Yeah.
Because it would be that population where metastatic cancer, life expectancy less than months, and that you were doing this for true palliation, to in a low risk person to not go after either supraannular or intraventricular. It wouldn't make sense to me, but a lot of
Yeah.
things.
Yeah, and that was my point here, was that is that I think that in this case, this is the surgeon's role to certainly, if there's any question that you've got a low risk patient who did not get an acceptable outcome on the first trial, and to push for surgery. So this patient was managed, transferred over to the OR, intubated, and proceeded with the open AVR. And I did replace his ascending aorta at that time. And my point here is that the bailout strategy for this patient may be different than what you would do for another patient. For instance, the high-risk 80-year-old patient. That one, you might have a fighting chance, like Dr. Mahoney said, if the valve embolized into the ascending. But again, even if the valve embolized into the ascending on a low-risk patient, I'm not sure that I would push that, because I've certainly seen issues from that as well. But again, that decision making is just different depending on the surgical risk and the outcome you can get.
Kenan,
Yeah.
did you do anything else when you were transferring the patient to the OR other than intubating? Did you keep the delivery system in place or something to prevent the valve from moving around?
Yes, I did. I kept the confida through that so that the valve did not spin around in the left ventricle. If it had spun around, that would have been catastrophic. That's a great question. So the delivery system was still in. We cut down on the femoral artery to get that out. And then I, basically just flashed the cross clamp to get the wire out after I rested. That's a great question.
Thank you.
Yeah, no, it's important that the valve doesn't change orientation when you're doing that. Case 2, this is a 58-year-old male. He was reluctant about surgery. Like I said earlier, there are some patients who will shop around, and you can see the anatomy here, particularly in the LVOT, gets quite elliptical, and look at how asymmetrical the sinuses are. This non is very minuscule compared to the right and the left, and there's a heavily calcified raphe. He presented 2 days after his discharge back with shortness of breath, and then subsequently developed fevers over the course of a month, and ultimately was found to be bacteremic. And so he was transferred to UVA for management of his endocarditis. And I just sort of show this to show anatomies, like we were saying earlier, where I think the surgeon's role is to really pause and say, and maybe just turn down a case. And you can see this was the CTA we ultimately got when he arrived, and you can see there's a leak there and a leak into here, into the RV. And then this cross-sectional imaging shows it well. This is the bottom of the Tavr frame, and he's got a VSD right there. And it really, you can imagine 58-year-old, and this is the outcome. This was the surgical view of it into the into the root, and you can see this whole area right here is one large VSD, and that's a real challenge to fix. And all of a sudden, a low-risk 58-year-old now has what is certainly an outcome that's going to change his life, because that is a very hard problem to fix. The way we went about it was a huge patch from sort of over here all the way over to here, and patched it from the left ventricular side. I was worried if I patched it from the right ventricular side. If you go back to this prior scan, I just thought there was too much extravasation to other chambers of the heart, that I wouldn't get a perfect result, because it's really a VASD rather than a VSD. But I just show it as a complication that can happen. Case 3, this one.
Kenan, can I just make one point? I was interested in your comment about he had shopped around for different therapies, but it's to me, it's getting more and more confusing for our patients because of what they can read, but also what's on TV. I was struck during the Olympics that one of the more frequent ads beside the electric cars was the Edwards commercials directly to the people on transcatheter valves. So rather than dealing with the medical community, you're now seeing lay public being looking at television ads on what valve is the best for you and easiest for you. So it's not just what they can find on the internet. And these conversations are tricky.
Yeah.
Sorry to interrupt you.
No, I agree. I think, that's where it really is incumbent, I think, to have honest conversations with the patient. Obviously, honest discourse between the team about what anatomies they're willing to tackle when the patients are reluctant about surgery. Absolutely. But it's certainly interesting. I didn't watch those commercials during the Olympics, but it's certainly interesting to hear that. This third case gets at access. He was a 92-year-old male, had an aborted Tavr out of state 3 weeks prior, and it was aborted because he had a right iliac rupture. And I don't have the full CT scans in this talk, but you can see the new stent there. But looking at the pre-Tavr CTA, it looked basically like this left side looks, which is, prohibitive. So it's no surprise that he was ruptured. And then I looked at his CT scan for alternative access options. You can see IVC over here, and then he's got quite a bit of thrombus in his aorta. And it pretty much looked like that the whole way up. Looking at other alternative access, here's a sample view of his carotid. You can see it goes pretty much totally horizontal in one view. And if I were to really show you a video of what it looked like, it basically was a true full-on S or Z, and sort of how the carotid looked, and the right carotid didn't look any different. However, I think this is where the surgeon's role is critical, is to look and see, well, here we are at the sternal notch, and the innominate is right there in a relatively thin male. And we were able to do this with just a small 1 centimeter, 2 centimeter cut down purse strings in the innominate and deliver it that way. And again, I think it takes creative decision-making on the whole heart team's part to really examine every potential point of access in a patient like this. And you can also see over here, the left subclavian would have been equally tortuous and calcified as it got into the arch. So that was really that patient's only option, but it was a good option. And I think it's important to think outside of the box and really, again, not rely on cross-sectional imaging and still shots, but you've got to look at the CT scan yourself and scroll through it and find an acceptable spot. Case 4, this is it gets to another issue where surgeons, I think, are part of the conversation. And it's a 74-year-old patient this time. He's a golfer. He's decently active, but I'd say golf, most active thing he does. Pristine access, heavily calcified leaflets, ascending aorta 4 centimeters, generous sinuses, area is 540. And you're probably looking at a 34 core valve or 26 versus 29 sapien. And he's open-minded about results. He had no coronary disease. Let's throw a poll up and see what people would choose here.
Okay.
It'd be nice to see the LVOT a little bit as well. Maybe you'll show that in another slide.
I might have it. So here, 95% chose Tavr. I didn't have the LVOT pictures in this particular talk, but I agree with you. So here our plan was, the area was 540. This was sort of right as low risk was coming out. And we hadn't really gotten into higher deployments on core valves. So our plan was to pre-balloon with the 25 balloon to help size. And again, nowadays people might choose a different strategy and have more of a conservative pre-balloon with that degree of calcium, and perhaps use a self-expandable valve, although there's probably even debate there because no one knows the actual correct answer. for this sort of patient. So I'm going to show the balloon valvuloplasty. So we did that, and then all of a sudden he became hypotensive. And so we rushed our deployment a bit due to extreme hypotension. We thought maybe it was AI from the balloon valvuloplasty, so we got the valve in. Still hypotensive. And we shoot this root shot, and I think hard to see probably on your screens, but there's a whiff of extravasation above the annulus. And then on TEE, you can see a posterior effusion here and anteriorly. And then a pretty impressive aortic hematoma developing along with persistent hypotension. And so this is a case of annular rupture. And again, I think it's more likely to happen in these heavily calcified bicuspid valves. And probably our balloon was just too aggressive. It happened to us on the balloon valvuloplasty before we deployed the Tavr. We put in a pericardial drain to try to stabilize it, but that obviously wasn't going to work in the case of a dramatic annular rupture. And in this case, emergent sternotomy, central cannulation, and found after I arrested that the injury was really through and through the aorta above the right coronary ostium and a very focal type A dissection. And you can imagine as a surgeon, in terms of the surgeon's role in the Tavr team, it all suddenly becomes very primary because the results of Tavr explant and a total root and pretty much a packed chest for a night. And, you know, he still plays golf, but there's no doubt I set him back. And, you know, I think that, like we said earlier, I think surgical risk and age isn't everything. I think anatomy is a lot. And I probably, we probably didn't press him hard enough on that, but that sort of anatomy. But it's interesting, 95% of the poll would have chosen Tavr, and that's what we did. And I think, it points to a few issues that I think now we've refined our technique in the past 5 years from when this case was done about how we deploy Tavrs, and we can get a better result, but it still leads to, you know, critical questions about what's correct. So with that discussion, I'll sort of add some questions for open discussion for the whole panel and the audience. Was A, is it necessary for surgeons to be fully independent in Tavr? Or is just teamwork with an adequate set of complementary skills, but shared decision-making, is that adequate? Same questions could both go for MitraClip, and then should Tavr and MitraClip be done everywhere and by both surgeons and cardiologists and be independent, or with the more advanced cases going to tertiary care centers, or is that just what's going to happen naturally? And I'll close with that.
Kenan, a lot of times surgeons get to inflate the balloon. I think that to add to the role of surgeon is know when to stop.
Yeah.
So, you know, it's a tough question from a cardiologist standpoint, because we'd love for the surgeons to be equally competent, but we can't really match you guys on the surgical side. So what we really want is a surgeon who can take care of the cases that we can't address with interventional techniques, or can help bail us out when things go very sideways, as you nicely showed. So do you think there's room in surgical training to become fully competent in all transcatheter therapies and also fully competent in open, or how would you allocate that bandwidth?
To me, I think it's important that they understand the technology and the limits of it, and understand the imaging, and can be valuable partners in weighing in on it. But I agree with you. I don't know that I think that they need to be fully independent. And, you know, but I do think that procedures should probably continue to be done jointly, or if they're not, that the incentives are aligned for the program to have good outcomes overall, regardless of which pathway the patient ends up on. But I'd say most hospitals are poorly set up in that regard right now.
I think that we're seeing in the evolution of the training that the surgeons, and I can't speak for the cardiologists, the surgeons are becoming much more ingrained in additional training and expanded training. Hey, excuse me. Hey, guys, in terms of not just taking extra time, three or 6 months, but formal training in transcatheter technology to include the mitral valve, tricuspid valves. And I think that will be the continued evolution as we're getting more and more specialized. The other point I would make as an editorial comment is I've never, at least in our center, the collaboration with the surgeons and the cardiologists have had huge benefit in just that integration. And as we've seen with the shock team, just the ability to have that dialogue with the surgeons, the interventional cardiologists, the critical care doctors in designing the best therapy. And the cardiologists have stepped up and have been much more aggressive in those shock patients rather than everybody going to surgery. And so I think that your point about one of your earliest parts of your slide was having that dialogue has been much more consistent and much more cohesive. And that's just only been expanded with, of course, our advanced heart failure, with ECMOs, with how we're dealing with the failed shock patients that are particularly in heart failure.
Yeah, I think that's been an awesome collaboration in shock. And I'm also impressed with how working together, a lot of the structural cardiologists also do advanced PCI, and sort of how that dialogue, I think if you have a surgeon in that space or that subspecialist at your hospital can sort of naturally delve into being sort of a joint coronary clinic for certain patients. It's really a wonderful collaboration. That's why I think the surgeon's role is so critical in the heart team and what it gets at, just, partners with cardiology. And I hope something that's not lost as we devise guidelines for how procedures should be done or patients should be evaluated.
Yeah, I would agree with, I think, what everybody's saying. I don't think it's necessary for a surgeon to be fully independent in Tavr. Like you say, Kenan, I think it's really important that we're familiar with the technology, that that we're kind of have relevant experience we can bring to bear during the procedures. But as your case is, I think, beautifully illustrated, our primary role is to be there when things go bad. And, I've had, over the years, I'm sure for you at UVA, you kind of get finishing fellows always asking, should I go do more structural this, whether it's catheter skill, wire skills, catheter-based stuff. And that's all great. But I always try to emphasize anyone who's finishing that your primary job and what makes you special is being able to open up someone's chest, put them on pump, and stop the heart and fix whatever problem there is. And so that I think always has to be paramount. For me, the way I view it, and just kind of getting into the mitral stuff, because that's predominantly what I do. When we started our MitraClip program here, I scrubbed on at least the first 100 cases. I feel very confident and comfortable doing a MitraClip, but I don't scrub on them anymore. But that experience for me is very helpful when I see someone in the office in consultation or in the valve clinic, and they're intermediate or higher risk. Because I feel confident and competent in the procedure, I have a good idea of what kind of result they'll get. And if I feel like they're a good candidate, technically for the procedure, it's a lot easier for me to kind of steer them in that direction versus say, I think the risk is going to be justified for a surgical approach because, just based on the experience, the catheter-based, approach isn't going to work as well for them. So I really think that's for, as surgeons, as we go forward, our role in the heart team is really going to be about how we kind of, keep our feet in both worlds, but obviously with the primary emphasis on what we do surgically.
Yeah, I mean, I felt like after my year, I would never have still the wire skills that a cardiologist would. But it's certainly being in the lab every day, managing the complications, and also seeing different strategies about how to bail out, what outcomes would be. To me, that's what I got out of that extra year. But I'm hesitant to recommend that year to trainees coming through now. And Tavr is not as novel as it was, you know, when I was coming through training. So I think they get better exposure to it now, personally.
I'd be interested in hearing from some of our cardiologists is, you know, we've heard the surgeon's perspective, but of course the comment could made that we've got a vested interest, as you made the analogy with PCI, but do the structural cardiologists feel that this is extra value? Do you, has this been a benefit? Where do you see this going forth? If you don't mind putting yourself out there.
Dr. Spear, maybe this would be a good time to pass it over to Dr. Mahoney again, who is also slated to give our last closing talk of the evening. So Dr. Mahoney, if you could address that real quick and then jump into your last presentation, that would be awesome. Thank you.
Yeah, I'll just for a moment to answer Dr. Spear's question. I think there's tremendous value in the joint heart team discussion. As Dr. Sarin was saying, knowing the limitations and the strengths of each procedure is helpful. Also for the patients who aren't really sure they're doctor shopping, if I'm in front of them saying, you know, catheter-based technology is not a good option for you, you need surgery, you know, there's some legitimacy to that. And if a surgeon says you should be good for structural intervention, that also works. I just really want to make sure the next generations of surgeons is as good as the current generation, you know, the older generation of surgeons at doing complex surgery. And I worry about bifurcating their training to do that. So it was interesting to hear the surgeon's discussion on that, because it's something we think about a lot. All right, I know we're running a little late, and I'll do my last talk. Let me share my screen, and I think Kenan, you got to thank you.
Oh, I'll stop. Oh, you got it.
Thanks. So this is kind of a blue sky future. Do I have it? Are you seeing it up there?
No, there you go.
All right. Are you seeing anything on your screen?
It says
No.
started screen sharing, but it's still a black screen.
Gotcha. All right. I apologize. I'll do it again. There it is. See something? Is that better?
Yes.
Very good. All right, guys. So I'm going to ask to talk about future for transcatheter valve interventions, and I'm going to talk about sort of the immediate future, because a lot of this stuff is either here or imminent. I'm speaking again from Norfolk. I'll spare you our beautiful pictures of Norfolk this time. We're going to talk about the rapid generation of transcatheter valve interventions. We started with aortic and Tavr, proved the point. We have a bunch of next generation valves for AS. We have dedicated valves for AI. We have expanding indications in asymptomatic patients and moderate AS. And we'll talk about, importantly, where I think a lot of the excitement now is in mitral and tricuspid repair and replacement. So aortic, we have new and next generation valves. We have Accurate Neo, we got Portico, Navitor, and Titan, Evolut FX and Sapien 4 around the corner. And we have dedicated AI devices. And the JenaValve for AI is up and rolling again. It's kind of exciting. It's our first dedicated prosthesis for pure AI. Accurate Neo is a valve that's almost completed its pivotal trial. It's a super angular valve, self-expanding 14 French, improved coronary access. It'll add to our armamentarium. Similarly, there's a recently approved Portico, has a generation valve right behind it called Navitor, which is basically Portico with a skirt and a slightly improved delivery system. And we've used both the commercial and the research variety here. Again, 14 French, very deliverable. But I'll move through. We have novel dedicated devices for severe AI, the JenaValve or JenaValve, depending how you say it. AI has been kind of a tough, thorny problem for a lot of valvular centers. We get referrals for pure AI because we take care of a lot of AS, and it doesn't exactly crosswalk over. The pathophysiology of chronic severe AS is a volume and pressure overload. There's initial compensation become pathological, and you get decompensated severe AR with LV systolic dysfunction. And then patients become symptomatic. And it carries with it a fairly high mortality tag, not quite as bad as severe AS, but a 72% mortality at 5 years, severe symptomatic aortic stenosis. So it is and if the NOHA class 3 to 4, the mortality is up to about 25% a year. There's a clear benefit of surgery. If the patients can have surgery, they should have surgery. Regardless of the left ventricular function, the patients tend to benefit from surgery. And the blue lines are survival with medical therapy. The red lines are survival with surgery. Not everyone can have surgery. So we've all tried current Tavr devices to treat AR. We've tried Sapien valves. We've tried Evolut valves. Very frequently, a second valve is needed to anchor it. The first valve serves as a very expensive anchor for the second valve, and there's still very high rates of PVL. You can see in the database, we have almost a 30% use of more than one valve. And then we still, even with that, we have a 15% moderate AI cohort. You're off label, so your institution is paying for both valves. Technical challenges, there's no calcium. All the Tavr valves we have now rely on the presence of calcium. And because this is often due to aortic ascending aortopathy, there's an annular dilatation present. And so these valves tend to be large. In fact, too large for most of the current Tavr prostheses. So the Trilogy heart valve system, which became the JenaValve, has some self-anchoring techniques. It has 3 paddles that come down over the leaflets, and then they help to self-anchor this. And these can be located under fluoroscopy, rotated. And here's a case example. You take your coplanar view, the valve is delivered, you can feel the leaflets, and they have a central self-expanding prosthesis to treat AI. So the Align AR is a trial designed prospective multi-center single-arm trial. Patients have to be high surgical risk. We're currently enrolling in that. We're about halfway through. So if you have a high-risk patient, we'd be happy to talk to you about them. In mitral, however, there's a ton of interest, both repair and replacement. We haven't talked too much about it today. It's been mostly Tavr centered, but let's talk about the, MitraClip. I used to joke the Easter Bunny, Santa Claus, and MitraClip 2.0 all had one thing in common. We're never going to see any of them. With the COAP trial, however, huge investment has gone into G4. We now have 4 different clip sizes for functional and degenerative MR indications. In the EXPAND registry, of which we led the U.S. in enrollment, 1,000 patients in the U.S. and Europe, we saw 94% of patients reduction of MR to 2 or less, and less than 1% procedural mortality. So this is a well-established technique, and in experienced hands, you can get reliably good results in a lot of anatomy, but not all anatomy. And we continue to wait for G4, G5, and G6, which are around the corner. We're looking at expanding indications in terms of the future for the PARA-MR trial. We're looking at MitraClip versus surgery for primary MR for patients at intermediate risk. And intermediate risk has been, we talked a lot about STS has less and less meaning. So intermediate risk is described as STS score greater than 3 or simply an age greater than 75. If the age is less than 75, STS is 2 or more comorbidity. So in the heart team's opinion, the patient is intermediate risk. If they meet those criteria, they're randomized 1-to-1 to surgery or MitraClip, and we're following those patients currently. Edwards has a competing device. I'll show it here to completeness. It's CLASP. It's a very nice device. We've used it at our center. It works quite well. It's a large device similar to the XTW. And the initial results from this have been exceedingly good, and we await the completion of that trial. In terms of replacement, the future is here for catheter-based mitral valve replacement. The complexities here and the challenges are greater than Tavr. There's apical versus transeptal approaches, although we're rapidly moving to mostly transeptal. The annulus is saddle-shaped versus circular. There's a wide variety of sizes, and importantly, there's a risk of LVOT obstruction that exists with this when the anterior leaflet and the valve complex can impede the flow out of the heart. It's actually been here for a while. We did with valve and ring and valve, and now importantly in valve and MAC, and we've added novel adjunctive techniques similar to basilica. We have alcohol septal ablation to save the septum. We have electrocautery laceration of the anterior leaflet, and multiple ways to perform this. That's called Lampoon. So valve, I won't bore you here, but it's a standard of care for failed mitral surgical valves for most patients. TMVR works quite well. You can see here a sapien valve and the transeptal, and you can see how beautiful results we get with 3D echo when we do transcatheter mitral valve and ring. That's now approved. Valve and MAC is a new frontier. The Mitral 2 trial is currently enrolling. We're one of 8 U.S. centers for sapien 3 and mitral annular calcification, and strongly encourages the use of adjunctive therapies, including Lampoon and septal ablation, to perform this. This is for patients with severe, a very difficult problem for the surgeons to tackle is operating on patients with severe mitral annular calcification. They can have both stenosis and regurgitation. This can be dense, but this can be taken as an opportunity to anchor a sapien valve in that position. Here's a patient with a prior Tavr who has severe mitral annular calcification, area of 610, a commercial distance of 31. CT modeling, however, showed one of the real hindrances. It showed a high risk of LVOT obstruction, a thick septum, and a predicted neo-LVOT of 0. So prohibitive risk of LVOT obstruction. The 2 options we have within the trial are alcohol septal ablation or Lampoon. They both have certain advantages. Septal ablation is technically straightforward, can assess results before proceeding with the event, can be repeated. It's a challenge, however, in thin septum. It's not feasible in all anatomy. It's off-label for an off-label for off-label, and there are pacemaker risks and VSD risks. Lampoon is not dependent on coronary anatomy, and that's where we lacerate the anterior leaflet. I'll show you in a second, and cannot always predict the efficacy of lampoon intraprocedurally. So we see a patient here with the appropriate coronary anatomy and a thick septum, septal thickness of 1.5. So septal ablation is performed. You wire the appropriate vessel. You put contrast down to make sure you're where you think you are. You confirm that with echo, that you're in the upper third of the septum. And an alcohol septal ablation is performed. We then repeat the CT scan. You can see the septal notch in the upper part of the septum here. That causes two things. It improves the area, shrinks the septum. It also makes that part of the heart hypokinetic or dyskinetic, which can improve the neo-LVOT. You repeat your CT images and you do an embedded valve, which is another virtual valve. The neo-LVOT is better, but it's still less than 100. So at that point, a lampoon was needed. And we can calculate both the neo-LVOT with the valve intact and the neo-LVOT, the skirt neo-LVOT. That's as if we remove the anterior leaflet. And what we do is we go in and lacerate the anterior leaflet, much as with the basilica, to allow the open cell architecture of the sapien valve to allow flow through. And this can be done in an antegrade fashion. It's a double puncture of the septum, 2 Agilis catheters, 1 lacerates, 1 catches, and you form a loop. You can confirm that on 3D echo. And we can confirm in 2D echo. We want to burn through the upper part of the anterior leaflet. We want to avoid the cords. We want to avoid the aortic valve. And then we're going to lacerate. Okay, we tighten up our sutures. We tighten up our wire. We electrify the middle part of the wire. We apply tension and pull back. And in the panel on the far right, you can see us lacerating the leaflet. The patients are not very stable during this. You can see there's a balloon pump being placed, and there's a lot of hemodynamic compromise when you induce this because it causes severe MR. So we move quickly. Here are some 3D images showing us grasping the leaflet, burning the leaflet, and we can see the result post-burn. You can see that leaflet's cut in half. And then you follow with the transcatheter mitral valve and MAC, which again, with predetermined CT angles, you can go ahead and place that and you get very nice results. The post-implant images show no LVOT obstruction. You can see in this patient, the frame goes all the way across to the septum, but we have no flow acceleration going out there, and the gradients were very acceptable, and the patient did well. We have dedicated mitral valve systems. I'll highlight a couple of them here. One of the issues with doing a transcatheter mitral valve is how to anchor it. With MAC, we use the calcium, but what if there's no calcium? So we can either have a large bulky platform, which some of them have to do that, or you can place a dock or an anchor in the valve and deliver a sapien-like valve. The M3 dock shown here, you place go transeptal, place a dock on the left ventricular side, encircling the leaflets, and then place a modified sapien valve in the middle of it for a final implant. There are competing systems. There's a high life system that does it retrograde aortic, but we like the M3 system. And that's the one we're using here. Here's a patient with severe MR and a dilated left ventricle. They're brought to our cath lab using 3D TE. We very carefully place the dock in the medial commissure, cross, and then using a combination of echo and fluoroscopy, we place the dock and we encircle, which is the name of the trial. You encircle the anterior and the posterior leaflets. Once that dock is in place, and you can see by TE, you can actually see the dock on the outside of the leaflets. And once the dock is in place, you simply follow it with the sapien-like valve, and that sapien-like valve plus the dock plus the leaflets forms a seal. And the patients, we've had excellent results using this valve. We're up to about 13 or 14 of them at this point. Postoperative day 2 echo shows the valve secured and in good position. There are other systems. Medtronic has the Intrepid TMVR. This is a hydraulic system which releases the valve through a pulley. This was the one we started with. We did about 7 or 8, but it was transapical at that point. It's now become transeptal. And so this is a transeptal system that's going to see increasing use. And I know other sites within the state are using this valve as well. I'll move along quickly in the interest of time and talk about tricuspid valve technologies. As in the mitral, we have both repair and replacement. We have edge-to-edge repair with the Triluminate, which basically uses a G4 XTW valve clip to approximate the leaflets. And we have the Evoke trial, which I'll talk about in a second. Here's a patient, again, with severe TR, pretty much wide open. Tricuspid's interesting because we've actually changed the scoring scale to allow for different results. It now goes from 0 to 5, so there's now 6 grades of TR. This patient has all 6 of them. With this device, it very much like the MitraClip, you grasp the leaflets. It's very much echo driven in multiple views. The leaflets are very thin. This is a challenging, technically challenging procedure, but it is reproducible. This patient received 2 clips, and you can see pre and post, pre on the left and post on the right. You can see we have a reasonably good result. With tricuspid clipping, you rarely eliminate it, but any reduction in TR tends to yield a clinical benefit. And again, seeing pre and post here. But it remains technically challenging. The results are not as impressive as it would be if we could just replace the valve. And so there's a lot of interest in percutaneous tricuspid valve replacement. There are several versions of this out. There's an Intrepid version. We're using the Edwards version. There's the Evoke valve shown here for severe TR. This is a very nice system. I'll show you a case we did recently here at Sentara. We have severe TR, and you can see the anatomy here. The Evoke valve, it's heavily imaging dependent, multiplanar reconstruction. From a catheter standpoint, you're doing a lot of standing while the echo people talk back and forth, so interplay is critical. A wire is placed into the apex of the RV, and it's followed with this system, which is steerable in multiple planes, much like the MitraClip is. You can see the anchors out here starting to come out, and you very slowly push the anchors out, and you can see the guidance here. This little T-shaped device here becomes a little bit broader. You keep feeding out the anchors using both fluoro until you get a proper position where you can deploy the valve, and the valve works right away. It's very exciting to place one of these valves and to see a result when we get to the final result, where you get essentially trace or no tricuspid regurgitation. The patients do quite well. These go home within a day or two in a percutaneous procedure that we're doing in a cath lab. So summary, now you see these people dancing because we have so many new exciting technologies. Try to guess which one of these is me. It's the tall one that's barely moving. But transcatheter valve interventions are here. They're being used frequently and they're improving rapidly. Repair and replacement are both offered. We have, within the state of Virginia, we're blessed to have multiple sites that can do both repair and replacement on both protocol and commercial basis. And I would urge you to keep clinical trials in mind when you find patients for whom you don't have a great answer at your own site. We have Repair MR, Clasp, Empty and Circle, Apollo, Intrepid. We have a line. So there's a therapy for many of the valve issues that we've struggled with. So, and there's a lot of resources within the state of Virginia that can help with this. So I just want to go through some of them, and I'll open it up to questions or comments from the other faculty. All right. Or maybe not, or maybe I just talk so fast I put everyone to sleep, Sherry. I don't know.
That was a great talk. A couple reflections is that obviously Repair MR and Primary are sort of exciting trials in our space. I'll be curious, what they show based on how they're designed. But that's certainly, as patients shop around for mitral options, that'll be a very relevant trial, particularly Primary, because it's going to include all low risk, any risk patient, 65 or older, for mitral valve repair, which this will be the first time that MitraClip will be introduced to that patient population. And we're sort of looking at 5 and 10-year outcomes. That'll be really interesting.
Yeah, I think so. I think again, the heart team is critical here. Having our surgeons be aware of what options we have for high risk or patients that they feel like they can't get a perfect result, and also knowing the limitations of what this technology can do. It is exciting, but it's not for everybody. And sometimes patients get caught up in the newness of it. We got to make sure that we keep tried and true therapies for people for whom they're good surgical candidates as well. But there's a lot of people out there that are being undertreated, and we have the ability to address a lot of these previously untreatable problems. All right.
I certainly share your your concerns about transcatheter mitral valve replacement, sort of its Achilles heel, and then similarly in reverse, the sort of Achilles heel of transcatheter tricuspid valve repair, because I imagine most surgeons who are on this would agree that in the high-risk patients with tricuspid valve disease, I wouldn't give a second thought about replacing that valve surgically if they were high risk. Just get in and get out with the replacement. And certainly now Evoke is a good option in terms of a trial option for those patients.
Paul, congratulations on the work you've done there. And I wrote a little chat to you, but it certainly deserves to be focused on. It's very impressive. And I'm struck also with the accelerated device ingenuity in these last almost 5 years, where we just had the Medtronic device, and now look at what's on the market, and then the advent and growth in the tricuspid space as well. So there's all kind of hope and promise of how this is rolling out, and the ingenuity that's being done. So great job, and thanks for sharing this with us this evening.
I appreciate the opportunity to speak to you guys.
Well, very good. We appreciate everybody's participation this evening. One other thing I want to mention is that VCSQI is rolling out the TVT database to our members. So that is going to be included in your membership. As far as TVT goes, there will be kind of an upload process similar to STS and ACC, like we've done for the other registries. And there's just so much good material tonight. I think we could have gone on for a long time, and we are planning on another meeting, quarterly meeting here, either later this year or early next year, regarding some of the other transcatheter therapies, and we can dive deeper and see what other new technologies have arrived by that point. So just really want to thank all of our presenters this evening. Are there any final closing comments from any of our members tonight?
Great job, folks. Thank you. Very enlightening. Really appreciate it.
Fantastic presentations.
Wonderful. Thank you, everyone, for joining. Thank you for being part of VCSQI.
Good night.
Thanks.
Good night.